Birth Society. I'm Dr. Chitra B. Pillai, consultant emergency physician and intensivist, a proud student and colleague of Dr. Anish Ghosh, myself, will be teaching you today's sessions along with our chairpersons and lecturers to get to you a very amiable content as the conference aims at. I kindly request all of you to keep your mobile phones in silent mode and at all times follow COVID-19 protocols inside the hall. At first, I take the privilege to call upon Dr. Anish Ghosh, MS, Chief of Endocrinology, Anantapuri Hospitals and Director Consultant at Capstone Obesity, Diabetes and Endocrine Center, Trivandrum, to deliver the welcome speech.
Good morning, friends. We know it is almost 2.5 years since Corona has turned the table against us. It has interfered in every aspect of our life, be it professional, be it personal. Now that we have taken a full circle back, and it is time to start dealing and rather discussing science face to face. I conceived this program as the first face-to-face meet, but to my surprise, I saw in between there were a couple of face-to-face meeting happening in Trivandrum with exuberant participation, because everyone we all kind of fed up of these online programs. So it is kind of a fresh lease of experience which has come to our life like a breeze, having back to these good old days of discussing science in person. Having said that, ladies and gentlemen, let me welcome you all to this true academic feast. I have discussed with my colleagues and designed each and every topic, keeping in mind that there has to be clinics in it. I was just speaking to Basi sir, how important it is to have a clinical orientation in the wards. So I discussed and decided and debated on each topic, making sure that there is something for us to discuss. So please use your opportunity to raise questions, suggestions, etc. during the discussions. Every talk will be followed by 5 minutes of discussion. So let me remind you again, I take this opportunity to invite you all again to this August symposium. I hope, wish, pray that everything go fine. Thank you so much.
Thank you for that cordial salutation, sir. Without procrastinating, I would like to introduce the chairpersons for the first session. Dr. Harish Kumar, Professor and HOD of the Department of Endocrinology and Diabetes, Amrita Institute of Medical Sciences, Kochi. And welcome, sir. Dr. Raj Mohan L., Senior Consultant Endocrinologist, KIMS, Trivandrum. Welcome to you too, sir. Over to you.
Good morning, doctors. Me and Dr. Harish Kumar sir will start off the proceedings. So let me start in the usual way by thanking Dr. Anish Ghosh for asking us to chair this first important session. And hopefully we'll have an academic feast for the whole day. There are a lot of good topics lined up. So before taking too much time between Gina and the talk, let me introduce the first speaker. I think the details will come up. The first speaker is Dr. Gina Susan George, consultant endocrinologist at General Hospital, Ernakulam. She'll be talking about art of communication reassurance and assistance in appropriate decision making in the setting of pregnancy with TSH more than 10. Over to you.
Good morning. Thank you, sir, for the kind words of introduction. At the outset, I would like to thank Dr. Anish Ghosh, sir, and the CODE's organizing team for giving me this opportunity for a junior like me. Sir was a constant support and guide during my DM training days as a part of the Travancore Endocrine Associates, the meeting which used to be held monthly. We had great academic discussions. So today I've been asked to talk on the art of communication, reassurance, and assistance in appropriate decision making in the setting of pregnancy with TSH level of more than 10. So I am sure that no one in this crowd won't be having any doubt whether or not to treat an antenatal lady coming to the clinic with a TSH of more than 10. So it has been proven over the decades beyond doubt that, and it has come up in guidelines also, that a level of TSH needs to be treated. But what data can we gather from the existing literature so as to make our day-to-day practice more confident and so as to counsel the patient in a more meaningful way? An anxious hypochondriac antenatal lady coming to our clinic, how can we offer a meaningful counsel? So as I searched on the literature, as expected, since it was proven before beyond doubt, there was no much data regarding whether or not to treat, and extrapolating the data was actually filled with whether or not to treat a TSH of between 2.5 and 10, the details which will be dealt by Sriram sir in the future talk, in the upcoming talk. All these studies which had been there were of a retrospective manner, and considering the manner of the condition, it is unlikely that a prospective randomized control trial will come up so as to give more data on that. So coming to the topic, brief glance on the physiology. So pregnancy gives an increased demand to the thyroid gland, so that the fetus needs more of thyroid hormone, and coupled with the increased metabolism happening in the mother also, which is somewhat compensated by the increased level of HCG, which acts on the TSH receptor present in the thyroid, resulting in increased T4 and TSH suppression. And I remember my HOD saying, Professor Dr. Jabas is saying that even a normal TSH in the first trimester should be taken with a pinch of salt. And there is an increase in TBG also, which leads to increased total T4 and T3, and an increased urine iodine excretion resulting in increased iodine requirement, and activation of placental deiodinase 3 resulting in peripheral T4 and T3 degradation. So pregnancy actually serves as a stress test for the thyroid gland. And so this is a graph showing the changes with a corresponding to a peak in HCG. There is a decline in the TSH level in the first trimester, and there is an increase in FT4 level, and the total T4 along with the TBG increase happens starts by 7 weeks and peaks at around 16 weeks of gestation. And as you know, fetal thyroid gland is not mature, functionally mature till 18 to 20 weeks of gestation. So the fetus is at this stage is entirely dependent on the placental transfer of maternal T4 at this stage. So coming to few cases, these are hypothetical cases, but we do often come across such scenario in our day-to-day practice. So this is a 6 weeks antenatal lady who is a known case of autoimmune hypothyroidism, taking thyroxine supplementation, and her TSH was 15, it was elevated, and T4 and T3 levels were normal. The second case is again antenatal lady at 10 weeks with TSH of more than 100 with low T4 and T3. So what is hypothyroidism? It is TSH above the upper limit of normal for a trimester is considered as hypothyroidism. If we have the locally derived TSH range, we can use that. If not available, a TSH more than 4 suggests hypothyroidism. And when iodine status is adequate, the most common cause is Hashimoto's thyroiditis, and autoimmune antibodies are seen in 30 to 60% cases with elevated TSH. And the adverse effects on hypothyroidism depends upon the severity of the hypothyroidism, the time at which the lady presents, and the adequacy of treatment which we can offer. So based on the severity, there are three types: overt hypothyroidism, subclinical hypothyroidism, and an entity known as maternal hypothyroxemia, which has a TSH level in the normal range with low maternal free T4. So in overt hypothyroidism, there is an elevated TSH with low level of FT4, and it is seen in approximately 0.2 to 0.6% of pregnant women. And if adequately treated, there is no higher risk for complications, unlike those with untreated hypothyroidism. And subclinical hypothyroidism is again an elevated TSH with a normal level of FT4. So coming back to the case 1 with an elevated TSH with normal T4 and T3 comes is subclinical hypothyroidism, whereas an increased TSH with low T4 and T3 suggests overt hypothyroidism. So as I said earlier, pregnancy serves as a stress for the thyroid gland. So if at all the thyroid gland is compensated or compromised in some manner, either be it iron deficiency or some autoimmunity, it may affect the further course of the illness. So if the mother is already having autoimmune thyroiditis with normal TSH prior to pregnancy, this may progress to hypothyroidism during pregnancy. And those with subclinical hypothyroidism may go for overt hypothyroidism, and in those who are already hypothyroidism may require an increase in the levothyroxine dose. So this is the ATA 2017 guidelines. With no confusion, TSH more than or equal to 10 requires treatment with levothyroxine. So what are the complications of untreated hypothyroidism? There is an increased rate of first trimester or abortion. There is increases for preeclampsia and gestational hypertension, placental abruption, preterm delivery, and low birth weight, all which can be explained by the uteroplacental insufficiency, as thyroid hormones are required for the adequate vasculature within the placenta. And there is an increased rate of cesarean section and postmortem hemorrhage due to atony of the uterus, and increased risk for perinatal morbidity and mortality. And last but not the least, the risk for neuropsychological and cognitive impairment in the progeny. So let us look on to certain articles. So this was published early in 2000 by Abelovich et al., in which they studied around 150 pregnancies. They studied around 114 women with overt and subclinical hypothyroidism. And in those with overt hypothyroidism, the mean TSH came to around 33.46. So what they concluded was that if they were adequately treated, all the the maternal complications like abortions, preterm deliveries were mitigated to a very low extent. And but there was a 60% risk of fetal loss when not adequately treated. And regarding the progeny, we know very well that maternal thyroid hormone is required for the initial neuronal development in the first 20 weeks. And undiagnosed hypothyroidism in the first half of pregnancy can be associated with poor neurodevelopmental outcome. And when maternal hypothyroidism is due to chronic autoimmune thyroiditis, the offspring of the untreated women is at risk for relevant significant cognitive deficits. And this depends on the severity and early onset of the thyroid hormone deficiency. So this is the chart showing the thyroid development, the need for thyroid hormone for the neurodevelopment. In the first trimester, thyroxine is required for neuron proliferation and for neuronal migration, and this is the time in which the fetus is entirely dependent on the maternal thyroid hormone, the placental transfer of the maternal thyroid hormone. So this was a landmark study which was published in NEGM in 1999 by Haddo et al., in which this was a retrospective study. They collected around 63 women with TSH of more than 98 percentile, and they followed up their children. The children were around between 7 to 9 years old, and they underwent psychological assessment. Their intelligence, their attention, language, reading ability, etc. were assessed. And the mean TSH in the hypothyroidism group was around 13.2. And they concluded that children born to untreated hypothyroid women had an IQ score that was 7 points below the mean IQ children born to healthy women and women given thyroxine supplements. So There is no doubt that we have to treat overt hypothyroidism, but if treated adequately, the difference in IQ was not significant. So we have all this data, the guidelines are there, the literature is there, but all are actually silent on one vexing aspect, that should we offer termination of pregnancy in a case of overt hypothyroidism. And this is the MTP Act, which came in 1971 in India, and these are the amendments which were proposed which came in 2020. So medical termination of pregnancy is indicated to save the life of the mother for social indication and for eugenic reasons. And eugenic indications that which are cited are those which cause a substantial risk of the child being born with serious physical and mental abnormalities so as to be handicapped in life. So this serious physical and mental abnormalities is actually a quantitative one. So in this present era of patient-centered care, the mother's opinion about the possible psychoneurological impact of the unborn offspring should be taken into account. And one example is that usually what obstetrician faces a patient with uncontrolled hyperglycemia, which has an unplanned pregnancy coming with an HbA1c of above the target. They are advised abortion or medical termination of pregnancy, but we don't have the absolute cutoff beyond which there are a serious risk of complication. So similar to this condition, there are no guidelines or no data recommending that MTP should be done or not. When I searched the literature, there was an editorial which came in Indian Journal of Endocrinology and Metabolism by Sanjay Kalra, and they propose certain points which can aid as in while counseling the antenatal lady which comes to us. And what they suggest is that severity of hypothyroidism, overt hypothyroidism with a high level of TSH, which has been left untreated late into the pregnancy, at least late into the early trimester of pregnancy with a low T4 or a T3, has a major risk as compared to a mild level of TSH increase. And the iodine nutrition status. So what they say is that there was a study in Japan in which they showed that if the population is iodine replete, a minor elevation in TSH will not have significant outcomes in the progeny. And the study by Unikrishnan et al., which was conducted in Kochi, showed that the Keralite population were almost iodine replete. And if there was a past history of infertility, and this is a precious pregnancy, and this past history of miscarriage or fetal loss, and whether there is a past history of congenital malformation or an offspring with intellectual impairment, and whether there is a family history of congenital malformation or intellectual impairment, all these points should be taken into consideration while counseling the patient. And again, the patient's attitudes and beliefs regarding MTP should also be considered. So what they finally suggest is that in patients with overt hypothyroidism below 20 weeks of gestation, treat as per guideline with L-thyroxine, and if conception has occurred without difficulty and OH is severe, the overt hypothyroidism is severe, take a final decision should be taken after discussing all aspects with the patient. And as of now, MTP cannot be recommended unless there is a request from the patient. So coming back to the case, in the first case, which was a case of subclinical hypothyroidism, it is almost sure that there won't be much adverse effects occurring in future. Whereas in overt hypothyroidism, that is in the second case, actually the pros and cons should be discussed with the patient and a shared decision should be taken. And the decision should be finally left to the patient. The ball should be left in the patient's court. And regarding treatment, the recommended treatment for maternal hypothyroidism, as you all know, is oral L-troxin. And other thyroid preparations like T3, combination with T4 and T3 or desiccated thyroid should not be used in pregnancy. And a dose of 1 to 2 microgram per kg is the ideal one for treating overt hypothyroidism in pregnancy. And how do we target the TSH level? The maternal TSH concentration should be kept below 2.5. And if there is a locally derived range, it should be kept in the lower half of the trimester specific range. And how should we monitor? It should be monitored once in 4 weeks till 20 weeks and at least once at 30 weeks. Usually in our clinical practice, we tend to check frequently, but this is what as recommended by the ATA guidelines 2017. Thank you.
Thank you, Dr. Gina, for finishing on time for a start. It was a very nice presentation because you covered both the clinical aspects and also the latest literature in the field. I think she touched on a number of somewhat controversial points. If there are any comments or questions from the audience, we'll take that first. I think so. If you can speak into the microphone, there's one kept there.
Generally, subclinical hypothyroidism is between 5 and 10. You showed a figure of 10 plus or something like that. Or some labs have 4.3. So 4.3 to 8.6. Less than that is subclinical, or 5 to 10. But you showed a figure of more than 10, 15. And I think anencephaly and all, I think, is an indication for termination of pregnancy. If you have found out if it is okay for the mother. Dr. Murli?
Sir, anencephaly that was listed as the indications for MTP as advised by the MTP Act. Not that doesn't happen in hypothyroidism of pregnancy. Those were those conditions in which MTP should be considered as a must. And regarding subclinical hypothyroidism, it is possible. A TSH level of more than 10 with the normal T4 is possible. And if the T4 levels are in the normal range, it should be taken as subclinical hypo only. Free T4 as for pregnancy when considering pregnancy.
I think as regard to the upper limit, in pregnancy already it is brought down to 2.5 from 4.5. You make a diagnosis even when the values are 2.5 or above. So in that situation, I think 15 milli international unit as the cutoff for the subclinical. I don't know whether there are separate pregnancy normative data that you can accept up to 15 as subclinical, unless there are literature. Any opinion, Jayasri?
Thank you. Very nice presentation. I think if you look at the ATA guidelines, when they make a diagnosis of hypothyroidism, the most recent guidelines don't make a distinction between overt and subclinical. So they just say hypothyroidism, any TSH which is above the upper limit of normal. When they make a distinction between overt and subclinical is when they talk about complications, because the sort of the complications that occur with overt are different from that which is seen in subclinical. And I think currently the thinking is that we make a diagnosis of hypothyroidism based on an elevated TSH. Yes. Mainly.
Yes.
So the cutoff is I think Sriram is going to address in his next topic. No, not 15. So the current guidelines are saying above the upper limit of normal. If your lab does not have that, take it as 4. The Indian Thyroid Society has given it as 2.5, about 2.5 to be diagnostic. For pregnancy, yes, all this is for pregnancy. I'm not talking about the non-pregnant state. General population. In pregnancy, about 2.5 is considered. The Indian Thyroid Society and the No, absolutely right. I'm saying, but even about 2.5, particularly if antibodies are positive, they are saying consider treatment.
I think Dr. Sriram wants to add something.
Mike.
Already there is a lot of confusion. I think I will add more to the confusion and then we can clear, I think. Because I have my talk which is again touching on all these topics. Tamil சொல்லுவாங்க குட்டை நல்லா கலக்கிட்டு then it will clarify. I hope there is clarity after some 45 minutes. But just to answer sir's question, at least in the non-pregnant setting, the entity called subclinical hypothyroidism is clearly defined. It is not based on TSH. Elevated TSH with normal free T4 is subclinical hypothyroidism, irrespective of the level of TSH. Yes. So even with a TSH of 30, 40, somebody can have a low normal T4 for the lab. So for all understanding purpose, that is subclinical hypothyroidism. In pregnancy, as Jayashree has already pointed out, some things are changing. I hope in the near future, new guidelines come, and there should be real, guidelines means not confusing the practitioner. I'll tell you what are all the confusions when I'm talking. Thank you.
Thank you.
So Dr. Gina, I think what I've generally been doing is not infrequently I have a patient who comes, they're very anxious. The parents are there, the in-laws are there, there's some elevation in TSH, and somebody has suggested an abortion. So you mentioned that ultimately it's a patient's decision according to the guidelines. But patients are frequently highly emotional and not in a situation to make a decision. It depends on the way we counsel them. I think that's very important. My general style has been to reassure and encourage them to continue with the pregnancy, even if the TSH is 100 at 8th week or 10th week, because I think there is no clear evidence that that's going to cause a major problem. I do tell them there are some small risks. If I were to read out all the risks which you outlined in a slide, many women who don't know much about the subject would get alarmed and go for an abortion. So I don't think we should do an American style total information thing. I think it's basically reassurance. There's a small risk, but you go ahead. And I usually always add that life is like that. Nothing is perfect. Even if everything is okay, things can go wrong. Even if you have a very normal child, you might be tormented by that child all your life after the child is born. So don't read too much into these things. That's the way I generally counsel. I'm glad I found it reassuring that your guidelines also follow that. Any Basi sir?
Just a small comment. Theoretical point of view, free T4 is definitely the best. But in the Kerala scenario, Indian scenario, many of the laboratories free T4 assay is not accurate. So in that situation, definitely total T4 correcting for the increased TG will be the recommend. Because majority of lab in Kerala, India, free T4 assay is not correct.
Yes, sir.
1.5, 1.5, yeah. It is very common to get a wrong result.
I think with that we'll close the session. Thank you very much, Dr. Gina.
Thank you, sir.
The next talk is by Professor Muralidharan. Professor Muralidharan is a senior consultant endocrinologist. He was formerly head and professor of Medical College Thrissur. And he's also a close personal friend whom I've known for a very long time. He's going to talk to us about approach to subclinical thyroid dysfunction in the elderly population.
ചെയ്താൽ മതി. Forward? Okay, fine, thank you. Good morning, everybody. After a long spell of online meetings, we are now all reassembling. It has dual advantage. One, you can see many of your old friends on face to face rather than on the image level, 2D. You are seeing it 3D. And remember some of the nice things we all had for a very long time. And I am extremely thankful to the organizers of this meeting, the Coates and Trivandrum Endocrine Group, for inviting me to talk on the subject of subclinical thyroid dysfunction in the elderly population. See, what happens is, these subclinical disorders, it's all the results of availability of highly sensitive TSH measurement. Basically, it is a biochemical diagnosis. And strictly you go by the letter, you should not have any clinical symptoms or signs or anything, any clinical outcome, not only symptoms and signs, outcomes like complications. The laboratory features defined are a elevated or a suppressed TSH with normal levels of the T3 and T4 level. And for TSH also, to my understanding, the upper limit is put at around 10 milli international unit, after which you don't look into the T3, T4 levels, you straight away start the patient on treatment irrespective of what it is happening. So the questions here, is it time for us to rename these subclinical disorders as mild hypo or hyperthyroidism? Instead of subclinical, mild, not enough to produce symptoms, but it causes only an abnormality in the feedback regulation. And the second issue, this abnormality in the CSH regulation, if there is a discordance between what the pituitary senses as a T3, T4 and the tissues receive the T3, T4 signals. It need not be the same. The same thing has been discussed a lot in resistance to thyroid hormone. You can have a central, peripheral, a combined resistance. The same type of situations can occur in these people also. So that is the second question that you have to do. So what has happened to the TSH assay over the period of time? The assays are made more sensitive, and with the availability of monoclonal antibodies or against the different epitopes of the thyroid hormone itself, you have got higher levels of specificity of this assay, very high sensitivity. If you take what it used to be when I was a DM student, way back in 1975, the assay sensitivity was around 10 milliunit. But with the second generation assay which came, it has been brought down to 4.5, and with the third generation assay, now it is between 0.1 to 0.01. This is the level at which you think. And what is the advantage of such a degree of sensitivity? You can distinguish people with a partial suppression of TSH at the hypothalamic level to complete blockage of TSH at the same point. And you know that the clinical issues coming out of these subclinical conditions are basically related to a total suppression or stimulation of TSH levels at the hypothalamic level. This is the data which says at that time it becomes a symptomatic or clinical hyper or hypothyroidism. That is what you may have to probably consider here. We have to address a few issues. One is the prevalence and progression. Second is the clinical risk, for example, to the various systems as a result of this condition, even though at the time of diagnosis the patient may be totally asymptomatic. The risk that is involved if you leave them like that and don't treat them, and the benefits of treatment. What will be the optimal treatment you give to these people? And finally, is there a need for a screening program to identify these individuals? The prevalence as regard to is around 0.7 to 12.4%. This is the enhanced 3 data where they have analyzed 16,500 people, and 0.7% has TSH less than 0.1, and similar number with the TSH more than 4.5 but less than normal, and more common in areas of the world where mild to moderate iodine deficiency is reported. I think there is some missing up of slides. Some problems, some slides are missing. For subclinical, I will cover the subclinical hyper first, and then we will go to the hypo. The subclinical hyper, if you are considering, that can be either exogenous or endogenous. The exogenous is mainly because of excessive use of thyroxine, either intentionally or inadvertently, or when you do the intentional TSH suppression in people who have undergoing treatment for differentiated thyroid carcinoma. Whereas endogenous include the various thyroid diseases like Graves, autonomously functioning adenomas, or multinodular goiter. But in some people, you have got a transitory period of hypothyroidism, like a patient on antithyroid drug therapy when you withdraw the drug. Then after radioiodine therapy, because in this situation, the pituitary takes a longer time for recovery. The normal HPT axis will take even up to 1 year for the real set points are determined and made operative. The causes of late TSH which are not related to hyperactivity. You may have an abnormal or a low TSH, but the thyroid function, everything will be normal. This can occur in conditions like non-thyroidal illness or the sick euthyroid syndrome when they are recovering, psychiatric disorders, especially severe depression, administration of the various drugs which you use in the ICUs, pituitary or hypothalamic insufficiency, very often it may not be as florid, the thyroid failure at the thyroid level is complete and often florid. But when it occurs at the secondary and the tertiary level, it becomes more subtle or may not be as easy as that. And decreased age-related thyroid hormone clearance. And you can see that even normally as you become aged, the TSH levels also start going up. So you can see a 4.5 which is put as the cutoff point may not be applicable in the elderly people, because if you start treating them, you may land into trouble. They may develop atrial fibrillation or one of those problems. So this you have to consider. Regarding the exogenous versus endogenous, for example, the classical example is T4 suppression for differentiated thyroid carcinoma. T4 levels are very high or markedly elevated. But you find that the T3 levels will be either in the normal range or on the upper limit of normal. And if the T4 to T3 ratio is definitely higher compared to Graves' disease or autonomous adenoma, the levels of T4 are high, free T34 are normal. So we have to decide when to treat. You have to first repeat the values more than once. There is enough data to say that whatever value you get on the first instance, if you follow them up, after all they don't have any clinical symptom, it's a biochemical diagnosis. You follow them up with 1 or 2 more T3, T4, TSH levels. You can see even up to 50% of them, their thyroid functions or TSH level will fall into normalcy. A small percentage of them, maybe around 30%, progresses to hyper or hypo, and 10% to 15% remain exactly where you have started. This is what will happen. That is why you repeat it. Normal free T3, you have to ask for the medical history, whether there are any symptoms or suggesting that, and you have to do a clinical examination. And when you are really to put to the corner, you may have to do a technetium 99 scan. From that will tell you whether your thyroid is over-functioning or under-functioning. If you have got under-functioning, it will be either a thyroiditis or you are dealing with a thyroid suppression from any exogenous or endogenous diseases which will cause these things. If the scan is negative, you have to consider these possibilities. For example, patient recovering from thyroiditis, taking exogenous thyroxine, use of radio contrast agents in the recent past. That can also cause abnormalities because they are all iodine-rich materials. And finally, hyperemesis gravidarum or trophoblastic tumors. Of course, this will not come in the differential diagnosis in the elderly population, which is the area, but I just told it for the purpose of completion. What is the progression? Based on the initial TSH level, we have got 2 groups. The value between 0.1 to 0.45 and the value below 0.1. One is a partial suppression, second is a total suppression. The second factor which will decide the progression, if it is the second part, that is 0.1 or less, then the progression is definitely going to be higher, or the percent. Otherwise it is around 5%. The underlying disorder also matters. For example, Graves or adenoma, 4 to 5.5% is the usual progression to clinical thyroid diseases. But if the underlying disorder is multinodular goiter, which is seen. Very often they may be asymptomatic, but the rate of progression may be as high as 30% or above. And in these subjects, if you follow up in the MNG, 30% will become hyperthyroid, 23% remains suppressed TSH level, and 10% it normalizes the TSH over a period of time. Progression of autonomic functioning adenoma, there is a series where 159 people were evaluated. 14 of them became overly toxic in 6-year follow-up. Most of them had nodules more than 3 centimeter diameter. Clinical complications are more in this group of people with a large nodules. And finally, lesson is low TSH, autonomous adenoma more than 3 centimeter diameter. That is an indication for intervention at that point of time. Clinical symptoms and signs, most often noted with suppressive LT4 therapy for DTC, also after self-administration. Classical symptoms of toxicosis may be absent in the elderly population. Here is a click. That is, if you have got an old person, you don't expect the classical symptomatology which you expect in a younger individual. They may be apathetic, or you call it, or they may not have any symptom, but they are hyperthyroid and they run the complications of high thyroxine levels. Mood and what are the abnormalities you can see? Mood and cognitive dysfunction. There is very difficult to say a cause and effect relationship between TSH and mood changes. Because in elderly, there are umpteen number of reasons for mood changes to occur. Whether it is because of a natural occurrence or because of your suppressed TSH, it is extremely difficult. There may be associated dementia in many of these elderly people, and we don't know whether it is the cause of mood changes or it is low TSH, or it is the effect of the low TSH that the mood changes are occurring. There are cases of inattention and hyperactivity, attention deficit disorders, and cognitive dysfunction reported in these people. These are the observed clinical risks, at least fall into 3 major spheres: cardiac, bone, and psychiatric. These are the areas where it usually happens. The clinical issues of which you have described are more when the TSH levels are less than 0.1, even in the elderly population. This is an article which has come in New England Journal 1994. Low TSH is a consideration as a risk factor for atrial fibrillation. They have been described. So, even a patient may be otherwise normal, they go in for atrial fibrillation. This is the graph showing that low TSH, the values may be as much as 25 to 27% with the incidence of atrial fibrillation over a period of next 10 years. This is what you are seeing in these people. This is another report. Thyroid hormone has a direct toxic effect on the heart. It causes cardiac muscular hypertrophy, which produces diastolic dysfunction initially, but later systolic dysfunction as well. And ultimately they all end into cardiac failure as an issue. Similarly, there are more literature. Subclinical thyroid dysfunction might represent a potential modifiable, at least modest risk factor for cardiac disease and mortality. They have done cardiac MRI for a more precise assessment. And what I have found, they have analyzed women 44 to 71, untreated hyper had nodular goiter and no comorbidity, higher resulting heart rate and cardiac output than euthyroid people, and achieving euthyroidism with radioiodine reduce the heart rate, reduce the cardiac output, and some reduction in the LV muscular hypertrophy. So treatment is being proven to be effective based on cardiac MRI. The second area is the bone and mineral. We are seeing conflicting results. Subclinical diseases are all associated with no single opinion, conflicting results. The serum osteocalcin level, which is it is the product of the osteoblast, that is bone forming cells, is the bone formation, weak negative correlation. Lower the TSH, higher will be the osteocalcin, showing that there is a greater degree of bone remodeling. When the bone remodeling is more, that is osteoblastic, it will automatically trigger the osteoclastic activity also. And ultimately the bone content will be a net result of osteoblastic and osteoclastic activity. If blastic is more, you have more bone, clastic is more, you get less bone. That is as simple. And elevated urinary excretion of hydroxyproline and cross-linked polypeptide has been done in postmenopausal women. And telopeptide 1, which is again a bone resorption marker, is markedly increased with subclinical hyperthyroidism. Coming to fracture risk, TSH less than 0.1, a threefold risk of hip fracture and a fourfold risk of vertebral fracture. This is the report. And subclinical risk for fracture women with low TSH levels, more than 65 years of age, physiological hyperthyroidism, are at risk of new hip and vertebral fractures. There is another study available, again showing the same in JCM, which has come in 2014. Again, more reports suggesting BMD in older adults are markedly increased. So what will be the treatment for these people? There are definitely improvement in the quality of life. Whether it is a placebo effect or it is a non-placebo effect, the beta blockers can improve some of the clinical or subjective as well as objective. As I have told earlier, the increased cardiac output, the heart rate, and even muscular hypertrophy. They can definitely become with a beta blocker. Antithyroid drugs are to be used, but cautiously, because some of these people may rapidly go in for hypothyroidism. If they are hyperthyroid, they will go in for that. And the treatment can be beneficial, but still we need more information on that. The next question will be to look for whom to treat. Will you treat all the people coming to you? The younger individuals, less than 60 years of age, and they present with a TSH value less than the normal, like 0.45, you may probably observe them and follow up the TSH periodically, or do some simple cardiac evaluation like ECG or something like that. But if the elderly, more than 60 years, TSH markedly suppressed, less than 0.1, you have to use beta blocker and or antithyroid drug, depending upon the issue. If it is TSH is between 0.1 to 0.5, observe if there are no compelling risk factors. Like say, for example, the patient has diabetes, hypertension, or many other dyslipidemia, then you have to go with the treatment, not on the TSH-based issue alone, but on the basis of other comorbidity which will also contribute to the cardiac problems. And treat with the area associated with risk factors, for example, immobilization, steroid therapy, bone marrow, bone BMD score in all these people. You may have to probably go ahead with the treatment. This completed, but I have missing some slides of hypothyroid, subclinical hypothyroidism. Here again, the value more than 4.5. The first question that you have to answer here, I'll do without slides, unfortunately, I don't take away the time. So the issue here is if the value is more than 4.5, what is the normal TSH? It may be written in your laboratory report as 0.5 to 4.5. Do you really believe them? There are data on this matter. If you take the population, people have conducted large-scale trials in USA. They found that 90% plus normal people have a TSH value of 2.5 or below. So should we bring down the TSH upper limit from 4.5 to 2.5? In USA itself, there is controversy. If you take the AACE, American Association for Clinical Endocrinologists, they say yes, you have to bring down. Whereas if you take either European Endocrine Society or the American Endocrine Society, they said no. On one particular issue. See, what you have to understand, when you reduce the TSH from 4.5 to 2.5, the implication is many more millions of people will be going on thyroxine from that day, with associated cost, side effect, and need for follow-up of these people. So because of that, the general opinion is there is no need for revision of the upper TSH level from present 4.5 to something like 2.5. It will continue at 4.5 as it is given today. So what happens here when the patient has got a subclinical? They also have the same clinical outcome, like for example cardiac. Then they have got lipid abnormalities. These are the two major things. And third is neuromuscular issues. These are the three issues which are noted with subclinical hypothyroidism. See, regarding cardiac, there is definitely subnormal functioning of the cardiac system. For example, the heart rate will be lower, the cardiac hypertrophy may be there in these people, and because of the mucinous material as a part of the cardiac contractility also is going to be. So there is overall global cardiac dysfunction. And because of the associated lipid abnormality, you may get increased incidence of atherosclerosis or the atherosclerosis based complications on the cardiovascular system. So if you are cardiovascular system, this is something which occurs. Secondly, regarding the nervous system, people have been found to have myopathy. You are all familiar with the delayed tendon jerks which you are seeing, which may not be present in these people, but muscle contractility is definitely abnormal in these people. And secondly, if you take many of the muscle enzymes like CPK or LDH, you find the values to be elevated. And all these things will become normal if you put them on thyroxine. A small dose of thyroxine, these values will be usually reverted with normal physiological function. The same is true with the cognitive function and this thing. Here again, there are no unanimity, but definitely there is an increased number, and you find that these people, when they are put on thyroxine, they do this thing. Whether it is a placebo effect or whether it is a true effect, it is very difficult to say, but subclinical hypothyroidism is another equally important issue which need to be addressed, and there is a selected group of people. You may have to give the treatment, and that will definitely make better result. So, I have tried to cover, unfortunately, the group of slides are missing. Thank you very much for the patient listening.
Thank you, sir. With this rich clinical experience, it's nicely elaborated on subclinical thyroid disease. If I'm, with your permission, if I can conclude, for subclinical hyper, we try to treat more often compared to subclinical hypothyroidism, because subclinical hyper has more implication for the elderly population, whereas subclinical hypo, with the symptoms the patient has, we can tend to treat those patients. So if any questions from the audience, please.
Can you use a mic? I am a little bit...
Should be treated because of the cardiac implications?
Yes, subclinical hypo in the elderly, if they have got problems like hyperlipidemia, contractility problem also, you do them, give them treatment, but you see the target CF or TSH level not at 4.5, between 6 and 7. You don't bring it down. Suppose somebody has got a 10 milli-international unit, you try to make it around 6 or 7, but not to 4.5 or below. Normally when you treat, your optimum will be, you want to keep it around 2.5. You don't go for that in a patient with a subclinical, especially in an elderly individual.
So in that 44 to 71 age group, you said MRI showing those changes, no? You said you would treat with radioactive iodine. Why not antithyroid drugs?
Both of them are effective. There is no consensus. Some people use antithyroid drug and some people use the radioactive iodine. But nowadays, overall, if you consider globally in the management of thyrotoxicosis, radioiodine, if there are no contraindication, is the preferred mode of treatment. Because it is much more simple, a single day treatment, annual follow-up is all that you need if the patient is stable, whereas you continue on the thionamides, you take continuous lifelong treatment, at least a 3-monthly follow-up and lifelong treatment. So that way, I think, but your choice is this thing. You can either use radioiodine or thyroid, antithyroid agents. Both of them are useful.
No, another thing Dr. Harish was saying, TSH above 100 in a pregnancy would possibly still continue, but there could be legal implications. If the child is cognitively becomes severely impaired. So you should take the consent.
About the last topic, about the previous topic.
Including the last session, that
Last, all right. Yeah.
TSH above 100 in
Yeah.
pregnancy, you may not,
I think even
you
if
may, I mean, it may be plus minus.
Yes.
There could be cognitive and legal implications. The child is
I think
severely
it is
cognitively impaired.
certainly. I think you need to certainly tell them that there are certain implications, but not alarm them, because the chance of this is actually very low. And if you sort of highlight all the negative factors which may happen, then it tends to cause unnecessary panic. That was a message I was trying to convey, because I think we tend to now become too defensive in our approach and cover ourselves because of this fear of legal implication. As a physician, generally I feel my threat perception about legal issues is little less. So I usually reassure patients. That's my personal approach. But if you're very scared about legal things, you should list out all the possible complications that can occur and then let the patient choose. But again, that's my approach.
Can I put
Only
another
sir,
word on that if time permits?
Only sir, it is very nice to
Matter.
listen.
The same matter he asked right now. The thing is, I fully agree with what Harish has told. If you have got a normal pregnancy with no thyroid, no diabetes, nothing, are you sure that you will get a normal offspring at the end of the day? There is always a certain number is there. In thyroid, it will be mildly elevated. So that case you can inform the risk. And in pregnancy now, you have got better methods of assessment. See, many of the people during a pregnancy, what I am understanding, between the point of conception to the time of delivery, around 7 to 8 scans are done, ultrasound scan. You see, if there are any gross abnormality, that will definitely be picked up in any one of them. Whether it is a neural problem or a cardiac problem, they will all be picked up at some point or other. In that case, you can take a decision or advise them more strongly. Here there is an abnormality noted. It is better that you go in for termination. Otherwise, there is no point in scaring people. The moment you make a diagnosis, you go for MTP, sent to the gynecologist. I fully agree with Harish. Pardon?
Cognition cannot be seen in the scan.
No, cognition will not be. Even without that, there are many people with a cognitive disturbance born in the world. You see, you have to, what will you do with them? See, there is one more person added, that's all. But how many pregnancy you will be terminating? How many children you are? Yes, Basi, to me or the previous? Yes, Basi.
This subclinical issue, I was always thinking, you have definition is normal T3 and T4. And if you look at T4, the range is 4 or 5 to 11 or 12. Now, is it really applicable for a single person or a population? For example, we do not know the T4 of the person before the diagnosis of subclinical hyper or hypothyroidism. Suppose I am just saying that his value was 6 before the, say, 1 year ago. Now it is higher or less. Is it? That is a question which I always.
I didn't get your question clearly.
I will repeat it. You have a reference range. For example, total T4 5 to 11 or 12 or 13 depending upon the lab. Is it really applicable to the one individual, this range? Or is it only for the population?
Only for?
It is a population range. I am saying that a particular individual.
The problem is whenever you take clinical decision, It is all done on an individual basis. We cannot take a population as the thing. Population data will give you a guideline what you can do
അല്ല
for the
എനിക്ക്
people.
തോന്നുന്നു എൻ്റെ പോയിന്റ് സാറിന് കിട്ടിയില്ല.
No, the thing is,
റെഫറൻസ് റേഞ്ച് എന്ന് പറയുന്നത് റെഫറൻസ്
the
റേഞ്ച്
reference range is based on the normative data from the
എഴുതി
country.
I know that.
So it's not applicable for that patient, but we have to take it as TSH for that
My
data.
worry is suppose this particular patient,
So
we
I
previously we have
fully
done.
understand what you say. I think there is a concept that an individual's TSH fluctuates only a little bit.
Yes, that is exactly the
Your
point.
TSH may be fluctuating between 0.5 and 1.5.
Right.
And that may be your normal range. An
And
individual's TSH
same
doesn't
for
fluctuate
T4
much.
and T3.
But the population normal may be from 1 to 4 or whatever.
Agree.
So if you try to keep, so 4 for that particular individual may be high. I think we are going to have a discussion on that in the 5th talk. We are talking about persisting hypothyroid
It's not
symptoms.
applicable for T4 and T3 also, this range.
It is. So an individual may vary from the population normal and you need to consider that. I think we'll
But
have
that we cannot
a
apply
deeper
on an
discussion on
individual
that.
case, we cannot
Yeah.
apply that
No.
in that case.
I think we'll go for one last question. Yeah.
I'm not hearing, use the mic or it is not working.
Then there's one more mic.
So in patients with subclinical hypothyroidism, you have beautifully enlisted all the complications, the cardiac, the osteoporosis, everything. So does the prevalence of these complications differ among the etiologies, like Graves'
Yes.
disease or toxic nodular goiter, or just based on the degree of hyperthyroidism and the duration?
Well, in general, in elderly people, multinodular goiter with toxicity has got a higher prevalence of complication than either Graves' disease or some forms of thyroiditis. That is the overall opinion. But repeatedly data are coming and we cannot say this is what it is. You have to wait.
Okay, so let's thank Dr. Muralidharan sir the usual way for a nice talk on subclinical thyroid disease, and we'll move on to the next talk. Thank you. Thanks.
Sorry for the interruption. Tea is being served till 11 a.m. You could also help yourself. Thank you.
So next we have another eminent speaker who has come all the way from Chennai, Dr. Sriram Mahadevan sir. He is professor and HOD of Sri Ramachandra Medical College, Chennai, and he'll be talking about around the corners how to manage TSH range between 2.5 and 5 and 0.01 in pregnant people. So he will add to the confusion, I hope.
Thank you. Thank you, chairpersons, and profuse thanks to Dr. Anish and everybody else in the organizing team. And as the chairperson alluded to, as I was hearing the previous two talks, especially the first one, we have enough and more confusions. I wouldn't say confusion, that's how science evolves probably. And I'll try to add some more to the data and information available in the last 5 to 10 years on this important topic. And rightly so, they have given specific heading. How do you manage TSH range between 2.5 to 5, 0.01 to 0.1? You can see by the heading itself from the previous talks, we can understand that this is a third generation TSH assay. It is not the thing. So traditionally, if you are managing a routine primary hypothyroidism in an adult non-pregnant situation, it is not necessary to have a third generation assay actually. So only for cancer and other words. But because now everything is today, everything is universal. Traditionally, you need not have a smartphone for your routine functioning, but without smartphone, you can't do many things now. So it has become the order of the day. So TSH, and I am from a metro city, the assays, and some senior sir was saying that free T4 assays are not routinely available in many parts of Kerala, and true in many second tier towns. But with the newer kits coming up, free T4 has become the vogue. In Chennai, getting total T4 is more difficult. You send to a lab saying TFT, they will do only free hormones. So that's based on your practice, that's what happens. And I will try to go through this topic and try to get some sense out of it and what I understood. How to go to the next slide? Oh, sorry, remote. Oh, sorry. it's not in this computer. Forward. This, I think, first 1 or 2 slides I'll skip because thyroid physiology has been already explained in good detail, and we will go directly to what is normal TSH in pregnancy and what has been evolving in the last couple of decades. We know that, the HCG has a tremendous stimulating influence on the thyroid, due to which the thyroid is actually overproducing, and you can see how the TSH normally is suppressed. So to put it in a different way, or at least for conceptual purpose, please let us understand, or at least have a consensus, that pregnancy is, at least in the first few weeks to couple of months, is a mild hyperthyroid or thyrotoxic state. So the pregnancy is like that. That is how nature has devised it. And so we expect with these ultra gender sensitive TSH assays, the TSH will be always low, on the lower normal. As the first speaker, Dr. George commented that Dr. Jabbar sir used to say, that's what she said very nicely. So even if in upper normal TSH used to be given some significance in pregnancy. This is general understanding. How exceptions come into it, we will discuss more and more. I remember one talk by one famous diabetologist in Chennai. What is normal sugar? If you ask like that, suddenly you will get a shock. How to define, outcome based, etc. Same way, normal TSH, just now in the previous panel discussion we had, how normative data is derived. We take an average, usually 200 to 300 patients. I shouldn't call patients, normal pregnant ladies. They are not diseased actually, they are not patients, to be taken, and you do TSH by the same assay, preferably in the same kit, in a single go, with all the precautions. There are 2-3 other biological things. We are doing a small study on that now. We have too much of problem now. How do you say they are normal? Just by symptoms. Just now sir said how subclinical itself is, there is confusion. With respect to thyroid, if you are academically strict on this normal, generating normative data, you should prove that they are all iodine sufficient. They don't have any background thyroid problem, for which unfortunately you have to do a thyroid antibody levels to say that they are negative. So basically you should take 200 to 300 pregnant ladies in each trimester without iodine deficiency, or excess is probably allowed, iodine deficiency, without with TPO antibody negativity. That means they don't have background autoimmunity, no goiter and usual family history, and no previous abortions. You have some high risk. Such ladies, if you take and do TSH assay by an ultra sensitive whatever assay, cutting across all the same assay should be done, then you derive. Like that, as you know, in US and other places, they have done enormous studies. The first 4 or 5 studies are all from Caucasian and other European countries. Invariably, you see all the TSH in the first trimester are below 2.5, based on which the Western people documented that, okay, 2.5, let us take it as the cutoff. This is clearly a statistically derived formula, 2.5, which was there in great work. There are gynecologists, practicing obstetricians here. All are physicians, sir. Oh, okay. So okay, it will be, so except this, you see, Dr. Marwaha, our own person from North India, they did, this is one of the best studies done in India, where they tried to do TPO antibodies in everybody. We are finding it tough in our study also, because it's costly to do TPO on everybody and select only negative. See, in India, already in that study, which was included also, the upper limit in many patients are 5. The range is up to 5. So this was already a small spanner on that wheel, which was already going on, and between 2012 to 17, several other studies came. We tried to analyze 2 systematic reviews are published. This is with my colleague from Bangalore. We did one systematic review with which we were able to identify only 6 out of those 8 or 9 major studies, and Dr. Marwaha's studies was the best, where TPO antibody. And now we have 2 more data, one from Calcutta, and I think one from Kochi also probably.